Okay, we're going to talk about spinal cord injuries now and spinal region syndromes. And this will be the last section of chapter 13. You will also talk a lot about spinal cord injuries in neuro rehab class next quarter, and I know Jamie and Di usually bring in some patients with spinal cord injuries, so you get to work with them a little bit and meet them in the lab, and that's always fun, and interesting to talk to people and just hear their experience and what they've gone through in therapy. So traumatic spinal cord injuries are usually caused by motor vehicle accidents, sports injuries, falls, or penetrating wounds like a knife or bullet that directly severs neurons in the spinal cord. So usually in motor vehicle accidents, sports injuries, and falls, the damage is due to crushing or hemorrhage and edema, or infarction, where a certain area of the cord is separated from its blood supply. But so you can have different effects with all those different injuries. So immediately after a traumatic injury, cord functions below the level of the lesion are depressed or lost completely. It's called spinal shock. It's due to the interruption of the descending tracts that supply tonic facilitation to the spinal cord neurons. So during spinal shock, you lose reflexes, you somatic, autonomic, and you lose autonomic regulation of blood pressure, and so you get hypotension. So this is a really serious time during the traumatic spinal cord injury, right, initially. So a lot of times right after it happens, people are hospitalized. They might be on life support because of that lack of autonomic regulation. Depending on the level of the lesion, they require different levels of support. A lot of times they might have some sort of external fixation of the vertebrae, like a halo, just to keep from further injuring the spinal cord. And they also are often given high dosage corticosteroids to reduce inflammation. So you also get loss of control of sweating, and piloerection is your hair standing on end. So thermoregulation is a big deal after a spinal cord injury. So several weeks after the injury, with good treatment, most people experience some recovery of their spinal cord function, and you get some return of the reflex activity below the lesion. So you won't know for several weeks after the injury what kind of return people are going to get. So it's a scary time for a lot of people, and it's time when they really need a lot of support, medically and every other way. So in some people, after the initial spinal cord shock goes starting to go away, the spinal neurons are excessively excitable, and so you get hyperreflexia, and you're developing new synapses in the reflex pathway, and so that's kind of a lot of times their first return is they get that hyperreflexia. So first they have no reflexes, and then they have way too many. So after the recovery from spinal shock, usually the neurological deficit is considered stable. In other words, it doesn't progress, it doesn't get worse, and that stable period can last for decades. So people go through a lot at the beginning, and then they can start work. So a lot of times, you're working on basically saving their life in the initial stages, and then it's after they get through that spinal shock period when they begin working with us in physical therapy. So because you're not getting stimulation from the descending tracts, you lose lower motor neurons. The muscle fibers actually change. You get atrophy and fibrosis just from that loss of neural input. So that's pretty common. So you also get some interneuron activity alterations and abnormalities. And you don't have to worry about them too much, but really you just get changes in your sensory and motor effects below the level of the lesion. And those ones persist. So the little pathology boxes, like they have throughout the book, and they talk about all the different things. And a good thing to note, consciousness and communication and memory are all normal. Everything above the level of the lesion is normal for this person. So but the thing that's not normal is they have to learn how to now live their life without everything below the lesion. So there are two criteria that they use to classify a spinal cord injury. The first one being whether the injury is complete or incomplete. And I want you to know these definitions. The injury is considered complete if you lack sensory and motor function in the lowest sacral segment. An incomplete injury is preservation of sensory and or motor function, so it can be either one or both, in the lowest sacral segment. So the neurologic level of the injury is the second part of the classification, and so it's the lowest level, or they say the most caudal level, meaning the lowest level with normal sensory and motor function bilaterally. So the neurologist is usually figuring out the level. There is an internationally recognized scale for figuring out the classification of spinal cord injuries. It's called the ASIA scale. ASIA stands for the American Spinal Cord Injury Association, and there's a little picture of the worksheet basically that the neurologist fills out to determine the level of the lesion. So they do a lot of testing, sensory and motor testing, to figure this out. So normally we're not doing that, but knowing the level of the spinal cord, the neurological level, that lets us then know what the patient is capable potentially of doing and what sort of assistance and mobility aids they will need. So in terms of walking, anybody above an L2 lesion will need a wheelchair for mobility. Someone with a T7 to T12 lesion will be able to perform a sit-to-stand and walk with orthoses indoors. But to be able to walk in the community, most people with an L2 or above L2 will not be able to do that. And then you can look at this chart, which of course I don't expect you to memorize, but you can get an idea of what kind of assistance someone will need. So in order for someone to live independently, it has to be C8 or below. So if someone has above a C8 spinal cord injury, they will probably need assistance with their ADLs. They're, they can be pretty independent with a lot of things and figure out how to do things, but they're going to need some assistance on some level. So that's an interesting chart to look at. You'll certainly talk more about this next quarter in neuro rehab, but that's a good thing to know. There's just more information about the ASIA scale there. So knowing that neurological level, that then lets us know what we can do in physical therapy, and it's pretty important. So this is another picture of the ASIA scale. So autonomic dysfunction is really common during spinal cord injuries. During spinal shock, neural control of the pelvic organs is depressed. So people need they need to establish a regular bowel and bladder emptying routine, and usually they are catheterized when they're in acute care, and then they learn to self-catheterize. And so that's a pretty important thing, because urinary tract infections are a huge potential side effect of spinal cord injury. So Complete lesions at higher levels of the spinal cord cause more serious abnormalities of autonomic regulation. So you get loss of descending sympathetic control as a result of lesions above T6 that result in autonomic dysreflexia, and we'll talk about what that is, poor thermoregulation, and orthostatic hypotension. So poor thermoregulation, it interferes with your ability to maintain homeostasis, maintain your body temperature. So your body might compensate with excessive sweating above the level of the lesion, but below the level of the lesion, they're not going to have any sweating. So people with complete lesions above T6 need to avoid exposure to high temperatures because of risk of heat stroke, and to low temperatures because of risk of hypothermia. So that's something to really be aware of. So of course, severed axons in the adult spinal cord do not functionally regenerate because we have those inhibitory molecules. Scarring is an issue, glial scarring, and then we don't have that growth factor, that neuron growth factor in mature neurons. And so a lot of times you get functional losses secondary to the original trauma. There's the original trauma, and then there's bleeding and edema and ischemia, pain and inflammation. So in the acute setting, they're really trying to minimize some of those functional losses. So I don't have a slide on autonomic dysreflexia. I'll have to add that in. But I have some information in the module. So autonomic dysreflexia, it's excess sympathetic activity that's elicited by a noxious stimulus below the level of the lesion. So an example of that, and a pretty common one, is the bladder's overstretched, they can't feel it, and it precipitates increased blood pressure, a profuse sweating above the level of the lesion, and sometimes emptying of the bladder. It can be caused by something as simple as there's a kink in the catheter tubing and the increased blood pressure. So what usually happens is, the thing that people notice, either they say, well, I suddenly have a headache, or they start with the profuse sweating above the level of the lesion, and then you take their blood pressure, it's really, really high. So one of the things, they might have to catheterize, or if they've got a Foley catheter in, or a suprapubic catheter in, you might have to check the catheter tubing and make sure it's not kinked. With orthostatic hypotension, you get that extreme fall in blood pressure when you get into an upright position, and because they don't have the sympathetic vasoconstriction that we normally have, and they also don't have the muscle pumping action in the lower extremities. And so that's something you work with people a lot once you get into the stages of therapy. You can get them on a tilt table and gradually increase their upright tolerance. So that is pretty interesting, and it's kind of fun therapy to do with people. There's a little chart in the module that shows those different autonomic side effects and what levels are potentially involved. So that one's kind of nice to know. So we know that the spinal cord neurons do not regenerate. A lot of times they give them those high doses of steroid during the spinal shock period to try to reduce those secondary losses and reduce the severity of the lesions. Incomplete paraplegia has the highest rate of recovery during the first 3 months. So there's a list of common complications, and this is 2 years after the original injury. There's a little chart about the prognosis. So when they talk about the Asia scale, there's A, which is a complete injury with no motor or sensory function preserved in the lowest sacral segment, so that's a complete. And 6% of people with Asia A's are able to walk at the time of discharge from the hospital. That's interesting. I wonder how that works. But anyway, In Asia B, excuse me, it's an incomplete, and they have sensory function below the neurological level and into those lowest sacral segments, but not motor function. And 23% of Asia B injuries are able to walk at the time of discharge from the hospital. I'm assuming that the 6% of the Asia A's, they are people with low injuries. They're not people with higher injuries. So, they're in the lower lumbar or the sacral spinal cord injuries. I mean, that makes more sense. An Asia C incomplete, motor function is preserved, and more than half of the key muscles have a muscle grade of less than 3. So they're weak, but they have some motor function, and 50% of them are able to walk at the time of discharge. And an Asia D is motor function's preserved, and at least half the key muscles have a muscle grade of 3 or more. So we know that's anti-gravity, and 89% of them can walk at the time of discharge from the hospital. So obviously, what's preserved and how low the injury is are what determine your prognosis. Makes sense, right? So, typical complications after spinal cord injury: urinary tract infection, spasticity, chills and fever because of that lack of thermoregulation, decubitus, which are bed sores, and that's, not being able to move to take pressure off bony prominences. So where a lot of times we're teaching people pressure relief techniques. Autonomic dysreflexia, contractures, and that's also from not being able to move. Heterotropic ossification, which is where bone forms in areas where it wasn't normally there. And pneumonia, and the pneumonia is because of the diminished breathing capacity. Upright posture can provide some protection against urinary tract infection and pneumonia, and mobility can help avoid the contractures and the decubitus. So a lot of times you're getting someone into a standing frame to work on that upright posture. It can also help with keeping their bone strength up and just feeling better. Being able to stand upright like that, people feel a lot better. And that's important. Okay, so we're going to talk a little bit about spinal region syndromes. So when they talk about a syndrome, it's a collection of signs and symptoms that don't necessarily indicate a specific cause. So some of these spinal region syndromes can be caused by an infection or an injury. It can be a spinal cord injury, partial or something like that, but it's not necessarily a specific cause. It's just a group of signs and symptoms. So it can be 3 of these. It could be resulting from a tumor or trauma. Anterior cord syndrome interferes with pain and temperature sensation and motor control. So we know in the anterior part of the cord we have the lower motor neurons and some of the pain and temperature sensation. Central cord syndrome, it usually happens in the cervical area. With a small lesion, you get pain and temperature loss at the level of the lesion. With a larger lesion, and this is usually caused by a tumor or some sort of compression, in a large lesion you get upper limb motor function impaired because in the cervical spine it's all upper limbs, so the lower limbs and trunk are not affected in central cord syndrome. Brown-Séquard syndrome, below the level of the lesion you lose voluntary motor control, conscious proprioception, and discriminative touch ipsilaterally below the level of the lesion, and pain and temperature sensation contralaterally. So it's a hemisection of the cord usually that is involved in Brown-Séquard. So it can be from a tumor or something like a bullet wound or a knife wound that only affects part of the cord. Syndromes, also other syndromes that can result from tumors or trauma. Cauda equina syndrome, it causes sensory impairment and flaccid paresis or paralysis of the lower limb muscles, bladder and bowels. Bladder and bowel are almost always affected in cauda equina. So we know the cauda equina is that lower part of the spinal cord that's below L2. And tethered cord syndrome, we talked about a little bit in chapter 5. It's a developmental issue where the cord is physically attached somewhere, and growth causes stretching, and the effect, there's a lot of different symptoms that it can cause, and the effects depend on where the tether is and how much the spinal cord is stretched during growth. So vertebral canal stenosis, I'm just going to talk briefly about it just because you often run into people in physical therapy with stenosis. It's a narrowing of the vertebral canal, and it compresses neural and vascular structures. It's usually a degenerative disorder, and it's caused by, bone growth from arthritis or facet hypertrophy, bulging discs, or hypertrophy of the ligamentum flavum. And the ligamentum flavum is a stabilizing ligament that's on the inside of the vertebrae, and so if that is hypertrophic, it can start to degenerate the the vertebral canal, and cause neural symptoms. So when we were talking earlier about how positioning doesn't really affect the size of the spinal canal in normal people, with vertebral canal stenosis, it can affect. Usually for people with stenosis, flexion is a position of comfort, and extension is a position of pain or discomfort or increased symptoms. So there's a little thing in the book that talks about red flags for the spinal region. So signs and symptoms that indicate that the problems you are having may be due to a spinal cord lesion. So bilateral alteration or loss of somatosensation. If you get unilateral loss, that might be a segmental issue, that might be a peripheral nerve lesion, it might be, like a disc issue or something like that. But bilateral alteration, that's a signal. There's something wrong there. Incoordination. I mean, there could be a lot of things that cause incoordination, but that, in conjunction with some of the other red flags, can indicate a spinal cord lesion. Upper motor neuron signs, we know what those are by now. Things that indicate that your lesion is possibly a cauda equina lesion. Difficulty with urination or defecation. Those bowel and bladder symptoms are a big red flag for cauda equina. Decreased or lost sensation in the saddle area, they like to call it, and that's innervated by those sacral segments. And low back pain, unilateral or bilateral sciatica, lower limb paresis and sensory deficits, and decreased or lost lower limb reflexes. I have worked with several people with cauda equina, and a lot of times they have that lower limb paresis and a significant amount of pain and the bowel and bladder symptoms, but they get it back. So that's the nice thing. And a lot of times you're working on strength and mobility with people with cauda equina. So there is another phenomenon that's called intermittent claudication, and what it means is, what the definition of intermittent claudication is, you get cramping or pain in the calf or the foot while you're walking, and it disappears if you rest. And you also get decreased pulse in the lower limb and cyanosis. Well, if you get cramping or pain in the calf or foot that doesn't disappear after rest, it might be a spinal region problem. If it disappears after rest, usually claudication, when the decreased pulse and the cyanosis are kind of indications, a lot of times it's problems with the vascular system, so it's not a spinal region problem. So a lot of times they want to differentiate between that intermittent claudication, which is frequently a vascular problem, versus similar signs and symptoms indicating a spinal region problem. So we went through some of these differences between different parts of the spinal cord, because the assignment this week is actually doing some case studies and, given a case study and certain symptoms, figuring out where the level of the lesion is. And so we have peripheral and central lesions in some of the case studies, and even though I know that you guys aren't neurologists and it's not part of our scope of practice as PTAs to diagnose problems, sometimes going through these case studies is a really good way to draw all the information together, and that's why we go through these. So I'm going to wrap this up for chapter 13, and then next week we'll go on and start talking about some of the special senses, vestibular and visual, and the cranial nerves and brainstem.